Hello, I'm Rob Kidney and I'm here to tell you about the Children and Young People's Psychological Wellbeing Practitioners course, or CWP for short. What I'm going to cover today is the need for intervention in line to this course, the role of this course in addressing gaps in services and treatment. I want to outline the value of low-intensity CBT working and the role of the CWP, or the Children's Wellbeing Practitioner, in relation to that. I'd like to give you some brief information about the course, staff team, impact and testimonials relating to the course. The first and most important element here is the need for intervention. So a number of documents have highlighted the need for accessible services for children's mental health difficulties, not least of which guiding our development of services at the moment is the Future in Mind report. And this identified that 1 in 10 children need treatment for mental health problems currently. And that the impact of mental health problems are that they lead to a lower educational attainment. One example being children with conduct disorder will be twice as likely as other children to leave school with no qualifications. Mental health problems are also strongly associated with behaviours that can pose a risk to young people's health, such as smoking, drug and alcohol misuse, and risky sexualised behaviours. Strikingly, research tells us that 75% of mental health problems in adult life have already started by the age of 18. Looking at anxiety in particular, research suggests that 70% of children aged 8 to 13 will worry, but the intensity of that worry will be what determines whether they will then go on to access clinical services. So whilst 4% of children aged between 5 and 15 will meet the diagnostic criteria for a severe anxiety disorder, by the age of 16 this has risen as high as 20% and continues to climb. Comorbidity is also commonplace. The thing to notice about anxiety disorders as well is untreated that they tend to persist. So children with anxiety disorders are 3 times more likely to have an anxiety disorder in adulthood. And childhood anxiety is also linked to educational underachievement, illicit drug use into adulthood. If you look at the development of rates of depression, there is a relatively slow, short climb towards the prevalence of depression until you reach age 15, at which point these steeply climb up towards the age of 18. This suggests that intervening for children in this age group, or prior even to this age group, provides a critical intervention period. The costs associated for children's mental health difficulties have been estimated, according to studies, as between £11,000 and £59,000 annually per child. The lifetime cost of a 1-year cohort of children with conduct disorder alone has been estimated to be at £5.2 billion. There are costs of adult crime associated with a history of conduct disorder and the impact on a number of different systems, agencies, health, social services, education and justice. Evidence-based practice for childhood mental health difficulties indicates substantial clinical and cost benefits. However, only 6% of current spending on mental health goes to services aimed at children and young people. There also remains a significant proportion of young people who have difficulties related to mental health difficulties who are not able to be involved in education, employment or training. So one of the things that's important when thinking about the role of the CWP course is to consider the current structure of services and the gaps between them. Considering the services for children and young people's mental health difficulties, it could be considered that there's an element of fragmentation of the services offered to young people. There may be divisions in terms of the different lines of funding for different services between health, education, social services and employment that do not necessarily come together. There has also been a history of division between statutory and voluntary services providing for the needs of young people's mental health services, with a limited amount of interaction between the two. There are also divisions in terms of considering the physical and mental health needs of young people, which, as you may suspect, have a fair degree of overlap between them, but services may remain very segregated. A similar difficulty noted is the difficulty when a child reaches the age of 18 and the transition to adult services, and the arrangements in different areas between those about the continuing mental health needs of children as they moved and transitioned towards adulthood. Perhaps one of the most striking difficulties will be the need for young people to present with a level of difficulty that may be defined in many CAMHS service criteria as severe and enduring. This may mean that there is a very limited range of treatment options available for young people whose difficulties may be considered mild or moderate. And for those who are able to be acceptable to services, there are often very long waiting times for treatment from those services. Further evidence of that can be seen by a couple of studies here, Ford and Dean, which look at the percentage of people with anxiety or depression not in contact with mental health services. And this figure will be at around 35% for adults, but when you consider the availability and access of service for children, the figure is estimated to rise to 76%. So there is a question about the availability of integrated mental health treatments for children. Few children may be referred, that may be reflected in the previous slide. 33% of those with anxiety and 45% of those with depressive disorders, according to Ford et al., had no contact with any health service, primary and secondary, over the previous 3 years. Specialist treatment may be scarce. It may be hard to access, but having access services does not necessarily mean that you will then have access to an evidence-based intervention. Despite being the most recommended treatment in NICE guidance, a UK survey by Stallard et al. Of child-focused services suggests that only 1 in 5 clinicians are able to work predominantly through CBT. So having reached the service and got through all the different barriers, you may then not receive what is necessarily a NICE-guided intervention. This is also reflected on a number of reports. The final report of the National CAMHS Review in 2008 concluded that children and young people are still only receiving fragmented and inconsistent support. Support is sometimes provided too late in a crisis, and information is not easy to come by. A further review, a report on CAMHS by Professor Sir Ian Kennedy in September 2010, urgent action is called for to respond to the mental health needs of children and young people. Mental health services must be available and accessible, including through self-referral, and be integrated with other services, particularly through schools. And this led to the formation of the Children and Young People's Mental Health and Wellbeing Task Force, which brought us up to the Future in Mind. And a number of issues raised by Future in Mind include a lack of information on services, so no coherent data collection or incentives, the treatment gap, as previously mentioned, so a study by Green in the report suggesting that less than 25 to 35% of children with a diagnosable mental health condition access support, and the third point here being difficulties in access. So NHS benchmarking and audit identifies increasing demand, increasing waiting times, and increasing complexity. So there is a clear need for supporting mental health interventions for children. This is where the course comes in. So this is related to the value of low-intensity cognitive behavioural therapy. In adult services, IAPT has developed low-intensity working in CBT. And in the 3-year report of the impact of those additional low-intensity CBT workers, it's identified over the 3 years a further 4,000 practitioners, leading to more than 680,000 people completing a course of treatment. What supports these is the outcomes of those. So recovery rates consistently in excess of 45% and approaching those expected from randomised controlled trials, so replicating the outcomes of the NICE guidance recommendations. Furthermore, session-by-session outcome monitoring, meaning that 90% of contacts were able to have data attached to them. And perhaps most importantly, the lives of those individuals transformed, including more than 45,000 people moving off sick pay and benefits. So the value of low intensity has been established in adult services, and it's about applying this to children's services as well. The effectiveness of low intensity CBT has been established in recovery rates. The adult project supported step care as a means of increasing access to psychological therapies by bringing in low-intensity working. This established a number of intervention protocols for different common mental health difficulties and working in a more timely, more upstream manner, more with the mild to moderate level of conditions, leading those individuals towards recovery. And there are a number of studies which support the effectiveness of low-intensity cognitive behavioural therapy with children also. A further issue to consider is whether this approach is acceptable to the young people themselves. Some work by Farrand et al. 2006 surveyed children aged 13 to 16. For 73% of those responding, this was considered to be an acceptable offer to offer low-intensity CBT. Many, 40% nearly, also considered that a computer-based version of this would be acceptable, which was actually much more preferred than book-based self-help. 87% preferred to receive that help at home. Others, a lower number, would be acceptable to receive that support at school, but particularly if that was provided by a more familiar person. But what this shows is support for non-traditional self-help approaches, and perhaps reflects the needs for young people to be met where they are. Location, using different methodologies, technological solutions, emails, telephone. This really steps away from traditional face-to-face, one-to-one treatments in stigmatised settings, which was the least preferred option for young people. The role of the CWP is in delivering low-intensity CBT. This requires fewer resources than traditional individual therapy models, as highlighted by Bennett Levy et al., that there is a reduced number of sessions require fewer, shorter sessions, that it may follow a guided self-help format and could potentially be short-term groups as well. This is delivered by paraprofessionals, peer supporters, people trained to deliver low-intensity CBT. Therefore, there is less intense contact. The work may be more self-paced in accordance with the young person's need and broken down into bite-sized pieces. This level of intervention is offered to young people with low-level, mild to moderate common mental health difficulties. Ideally, mild to moderate complexity, but it may be possible to make gains in more complex situations with a focused piece of work. The kinds of presentations that the CWP will be addressing would be low mood or depression, panic, worry, generalised anxiety, sleep difficulties, phobias, stress, tension, difficulty self-organising, behavioural, emotional regulation difficulties, anger, self-esteem, social anxiety, compulsive behaviours low level, mild health anxieties, and assertiveness or interpersonal challenges. So a range of different presentations at mild to moderate levels of difficulty. And the kinds of interventions that a low-intensity cognitive behavioural therapist working with children would be able to deliver is around behavioural activation, relaxation, problem solving, cognitive restructuring, exposure and habituation or exposure and response prevention, worry management, and some social learning theory-based parent support, behavioural and emotional regulation strategies, computer-based CBT, lifestyle management, and also parent-led CBT as well. So the role of the CWP can begin to address some of these gaps that we've identified earlier in the presentation. There may be an ability to address some of the fragmentation, as CWPs will have a role in coordinating and signposting, supporting young people to access services, holding them in the gaps, making sure that they don't fall through the cracks. This can help to bridge and bring services together for a more coordinated way of working. Workers themselves may be drawn from voluntary and statutory services, so we begin already to work across services cross-collaboratively. In learning groups, a part of the teaching is about deliberately bringing people together from different services to share learning, understanding, and develop connections between services. The role of a CWP will allow an earlier intervention through step care, but increasing the workforce is a key element here as well. This will support the young people's ability to access evidence-based treatments as well, referring to the earlier slide about the number of practitioners who would use cognitive behavioural therapy interventions. The high level of outcome monitoring will support outcomes-led intervention based on the goals of the young people as well, increasing choice and access for young people accessing services, facilitating their preferences for different treatment models and ways of being treated, perhaps face-to-face, perhaps more distant, perhaps more broken down, but supporting the young people in those choices. This also brings about transformation in terms of the use of routine outcome measurements for practice. This is very important for clinicians. It can help to identify information that may have been missed, to detect worsening of symptoms, to reduce or forestall dropout from treatment, increases the speed to which good outcomes can be reached, improving outcomes overall, supporting shared decision-making, done with, not done to, and ensuring that the voice of the service user is heard, with specific feedback session by session from the young person for the therapist. Further evidence for this is identified by Weiss et al., with these slides indicating that the number of overall diagnoses that a young person may come and at the beginning of treatment and have by the end of the treatment. And what this shows with the green bar dropping is that ordinarily there will be an improvement for treatment as usual. When you add in evidence-based practice that the interventions, nice guided interventions are applied, then that outcome improves by a further 15%. And when we combine this with routine outcome measures as well, we increase upon treatment as usual by a third, so a further 33% improvement. So these are really important, not just in terms of accessing services, supporting the choices of young people, but very meaningfully in terms of their outcomes as well. The course itself is in relation to health education's identification that the workforce by 2020 will need to increase by 1,700 more therapists in order to meet the expected needs of young people. This is an important programme in increasing the workforce for children and young people and their families as well. This is a one-year programme, and there are two routes within this programme. There is a graduate route with students having needed to evidence level 5 study previously, and a postgraduate route from a level 6 amount of study prior to entry onto the course. Significantly, the programme also comes with some salary support and placement support. So £21,052 midpoint, band 4 equivalent for individual the employment of individual trainees, and further £12,000 per trainee for placement support to support the integration of the role and the intentions of the training into services. The modules itself cover 3 areas. The initial module on the context and values, working with young people in line with CYP IAPT, a second module on assessment and engagement, and a third module on the intervention skills for the therapist. This leads to the graduate or postgraduate certificate in psychological therapies practice, low intensity CBT children, young people and families. Aligned with this are the adoption of low-intensity supervision models. So PWPs need case management, clinical skills and line management supervision. So there's weekly individual case management to support the application of interventions and a fortnightly group clinical skills supervision to support the clinical practice of the trainee themselves. The programme also supports this through supervisor training, and we currently have 2 routes through that programme, either via a CPD route or via a PG Cert supervision course. The 3 modules take place over 45 days, 6 of which are based in the services themselves. The programme typically commences in April and finishes at the end of March the following year. On average, trainees will be 2 days a week on university working and 3 days in practice. They would typically train at band 5 with the intention of qualifying, train at band 4 with the intention of qualifying at band 5. Significantly, what this programme also brings is collaborative support. So there is an investment here around the management, assurance and support of the integration of the CWPs into services. There is a dedicated project team to support that. So we have Catherine Gallup as the HEI lead, Jonathan Parker as a clinical lead and Kate Sandell as the project manager to support the integration of the roles into services and help services manage any issues that come up as well, in addition to the course team training the trainees as well. And in that university programme team, myself as programme lead, Finn Williams as academic lead, and our tutors currently Tess Bloomfield, Annette McKinley and Kirsty Saville. Intentionally, our course team has a mixture of people with a background of having worked and currently working in CAM services, some CBT accredited, some PWP accredited, and some coming from a background of adult services, intentionally to support the establishment of PWP supervision methods and ways of working as well. So we're covering both children and adult services in order to support the integration of the programme. This programme will also be subject to evaluation, so we are looking to closely monitor and evaluate the impact and outcome of providing this training. Nationally, those measures are being set, but we've already undertaken our own plan for how we're going to measure the impact of this service, and that was something that we'll go through as cohorts complete the course. And that will be fed back to the National Steering Group as well. Not presented here, but related to this is a number of testimonials for the value of low-intensity cognitive behaviour therapy linked to the EAD programme, the Enhanced Evidence-Based Practice programme, which is the university's experience thus far in training low-intensity CBT workers working with children and families. Our feedback indicates value to both services and clients of those interventions. Thank you very much for your time. I hope that has been an informative presentation. I'm sure my colleagues and I will be very happy to take questions should you have them. Thank you.